Now, you showed me recently an appliance that you had a lot to do with, the Apnea Guard. Something that looks to be kind of a trial appliance that helps the dentist, figure out how far open the bite should be and how far forward the jaw should be when we as a laboratory make it as a final appliance, and it gives the patient instantly some relief. When they come in and you diagnose this, they're able to leave, it sounds like that day, with an appliance already instead of waiting a week for a lab to make one. Tell me a little bit about the Apnea Guard.
Yeah, the Apnea Guard, the onus for that was the questions that I get from new dentists starting. How do you do the bite? How do you decide where to put the jaw? How much vertical separation do you need? Is there a simple way to kind of try it to see if the patient's going to respond? And so based on those things, hearing that for many years, we developed the Apnea Guard, which is off the shelf, tear open the package, 2 trays that slide along a sleeve. You put some PVS in there, have them bite into it, and then set their jaw based on an algorithm that we developed, and the patient's treated immediately.
So it's just regular polyvinyl impression material inside of there. They bite into it, it sets, and that's going to lock it onto their teeth.
And it's not going to last a long time, maybe a month, but you will find out if the patient's a responder by using that. So if they're a responder,
before you commit to the big lab fee. And
exactly. So you can use it as a trial in that sense. Sleep labs may be able to use that as well, because it really doesn't have to be fitted by a dentist. The Apnea Guard's so simple that a physician, a nurse, anesthesiologist, they can pull that out and fit it to the patient in the lab, test them in the lab overnight, and say, hey, this thing worked. Make the appliance to fit right where we have their bite, and we know it's going to work there. So it takes some of the mystery out of where does the jaw go, where should I put it? And that's confusing for some dentists. Like they adjust it, and all of them are titratable. We call it titration when you make the little adjustments, and
to move
the high rack screws,
backwards and forwards.
To find that sweet spot. And so we've taken a lot of the mystery out of doing that, made it very simple. And it's low cost. It's going to be inexpensive for the patient and the dentist to try that.
So the sweet spot is we don't want to take them. We don't want to take them all the way out. If the symptoms would stop when they were only out, halfway or something like that, 50% of the way, 60% of the way, whatever it might be. And it's interesting you bring that up, because most of the dentists who send us impressions for appliances will take the impressions and send it with a bite, but it's a centric bite, which is kind of silly, because we could have done that on our own with the wear facets. It's really easy to articulate, full models, and we could have done that, and we're just kind of left guessing how much protrusion they want on this, and so we kind of guess and pick an arbitrary 50% number, but we never get a bite beyond that. And it's sometimes difficult to take protrusive tight bites, but this sounds fantastic, because they bite into the appliance, and then you move the appliance according to this formula,
it just slides,
and then you have 30 days to move it where you want, and when it's working for the patient, you take out the inserts and send that to the laboratory, and they make basically a permanent version of the appliance the patient has already worn and gotten used to.
Yeah, that's right. That's exactly right. Good. The Apnea Guard is, taking the bite. You talked about the bite. The Apnea Guard can be the bite that you send to the lab, like you said. Construction bites, we used to, I remember doing those for functional appliances back in the day when I did that stuff. So taking a functional bite is not hard. We know how to do that, and there's very simple devices you can use that are designed for dental sleep medicine to do that. So really, the bite is very important, and you don't have to go to the maximal jaw position. Almost never do we go way out like that. Really, you get a logarithmic improvement in the caliber of the airway with just a little bit of protrusion. And in one of the studies we did, I'm just still blown away by this. Tiny changes, half a millimeter of titration, improve the AHI dramatically. So you never believe that a half a millimeter of moving the jaw forward would impact the patient this much.
Really?
So you need very, very small changes. You don't need to strain the jaw. There's no need to dislocate the jaw and do all that stuff. So that's the cool part. That's what we're still learning. That's what makes it exciting, because it hasn't been all worked out yet.
That is amazing, that a half millimeter, because I guess it's a linear relationship, right? The mandible goes out half a millimeter and the tongue moves a half millimeter.
Well, it's not really exactly like that.
Right.
Because literally what happens as you go forward, the airway dilates sideways.
Oh, on its own, okay.
We didn't know that until we could have MRI images.
Mm-hmm.
And we're like, oh, it's all about moving the tongue forward, and that's what I talk to patients about. But really, it's about increasing the lateral width of the airway.
And that happens when the mandible comes forward as well. Okay.
So the mechanisms of action of the oral appliance is just being worked out too.
Okay, well that makes sense then to have a trial appliance like you're talking about, because like I said, as a laboratory, we just guess where to put the lower jaw. And so maybe we put it someplace and the patient's symptoms go away, but maybe we're 30% farther than we need to be. I would guess that the farther you go out, the more you tend to increase the side effects with these types of appliances and maybe the discomfort of getting used to them.
Yes, that's true. Now, there is what we call a dose effect, just like a drug. The more drug you give, the more response you get. So as the jaw goes forward, yeah, your airway opens more and more and more, but there's a point at which you have diminishing returns.
Oh, really?
Yeah.
Okay.
And so that's what I meant by the sweet spot. You
Right.
can actually pass up the best
Wow.
position of the
Okay.
jaw. And then there's a vertical component which adds a new dimension to how the appliances work. The Apnea Guard has a sort of a system for choosing the amount of vertical for the type of patient you have.